hearing to order. Good afternoon. I'm sure that Senator Moran will be here shortly, but I thought I'd get done with my opening statement, and then we'll go to the panel, and hopefully we'll have a few more folks here, but we need to get this on the road because there's a bunch of votes this afternoon. I would say good afternoon to all of you. I want to thank you for joining us to discuss the delivery of health care and the benefits to Native American veterans. Native Americans have served in every American conflict dating back to the Revolutionary War. However, they continue to experience unique challenges that greatly affect their quality of life and the timeliness and quality of care and services to which they are entitled. Recently, VA Secretary McDonough announced a new office within VA, the Office of Tribal Health, to help improve Native American veterans' access to VA health care. I am pleased the Biden administration is putting more focus on the healthcare needs of Native veterans, and I will work to ensure that these efforts get the appropriate support here in Congress. Yesterday, I reintroduced the Tribal HUD-VASH Act to build upon a tribal housing initiative between the VA and HUD that provides rental and housing assistance to veterans in Indian country who are homeless or at risk of being homeless. The bill also ensures that at least 5% of the HUD-VASH vouchers are set aside for Native veterans. Last Congress, I worked with members of this committee on several provisions to allow Native veterans to gain easier access to VA health care and VA benefits. We required VA to establish an advisory committee on tribal and Indian affairs, which has now met 3 times to provide advice and guidance to the Secretary on all matters related to Indian tribes, tribal organizations, and Native veterans. And we required VA to stop collecting copays from Native veterans. However, I am disappointed that despite Congress mandating VA to stop collecting copays by January of 2022, VA has still not implemented this law. Today, I want to hear from the VA about what they plan to do to make this right and ensure that our Native veterans have equal access to both VA and IHS healthcare facilities. On our second panel, we have representatives from several organizations who serve Native American veterans. I'd like to hear about their top priorities, what they're hearing from their members about access to VA and IHS services and benefits, including healthcare, transportation, and housing. Native veterans have answered the call to service throughout our country's history, and we all have a responsibility to ensure that they have access to the care and benefits that they have earned. With that, I think we're going to go to panel 1 introductions and for your opening remarks. First, on our first panel, I want to introduce from the Department of Veterans Affairs, Dr. Mark Upton, Deputy Undersecretary for Health. He is accompanied by Stephanie Birdwell, Director of Office of Tribal Government Relations, and John Bell, Executive Director of the Home Loan Guarantee Program. From the Indian Health Service, we have the Honorable Rosalind So, Director of Indian Health Service. She is accompanied by Benjamin Smith, Deputy Director of the Indian Health Service. I want to thank you all for being here today. This is a very important hearing. We will start with you, Dr. Upton. You may begin with your opening statement.
All right. Thank you, Mr. Chairman, and Ranking Member Moran, and members of the committee. We appreciate you inviting us here today to discuss our efforts to ensure that American Indian and Alaska Native veterans have access to the VA healthcare and benefits they have earned. Today, we'll discuss what VA is doing to improve the provision of benefits and services to these veterans, as well as our ongoing coordination with our partners in the Indian Health Service. American Indian and Alaska Native veterans serve in the military at one of the highest rates of all racial and ethnic groups. They also disproportionately suffer the medical and psychological consequences of service. They reside in urban areas and some of the most highly rural parts of this country and experience healthcare disparities that are aggravated by barriers to access to care, care navigation, and coordination. As a VA healthcare provider myself and a member of the Veterans Health Administration senior leadership team, it's personally important to me that we strive to achieve the absolute best access, experiences, and care outcomes for veterans, and that we work to eliminate healthcare disparities. VA is committed to ensuring that our Native veterans receive the outstanding care and benefits they so rightly deserve, and that we use the authorities you've provided to us under the Pact Act to the fullest extent. We owe Native veterans our best. VA and IHS have worked collaboratively for decades to advance the healthcare and well-being of American Indian and Alaska Native veterans. VA and IHS first drafted a memorandum of understanding in 2003 and in 2021, VA and IHS made our most recent updates to the MOU through a formal process of tribal consultations and urban confers. The revised MOU reflects the evolving healthcare and health information technology landscape, and for the first time, VHA and IHS have worked together to create an operational plan. This plan includes strategies, objectives, and measurable outcomes for implementing the MOU's goals. This year's operational plan is currently in the midst of tribal consultation, and we greatly appreciate the feedback from our tribal partners. As you mentioned, Mr. Chairman, VA appointed the first ever Advisory Committee on Tribal and Indian Affairs on October 4th, 2021. This committee provides advice and guidance to the Secretary on all matters related to Indian tribes, tribal organizations, Native Hawaiian organizations, and American Indian and Alaska Native veterans. We are grateful to Congress for the legislation that allows veterans' voices to be heard so that we can best meet their needs. I personally had a chance to meet with the committee a few weeks ago and truly appreciated the thoughtful engagement and dialogue that we had. In order to provide Native veterans the healthcare and benefits they have earned, it takes a whole of VA approach. VBA offers a variety of benefits to Native veterans, including our VBA Home Loan Benefit Program that provides eligible veterans the opportunity to purchase or construct a home with no down payment, no mortgage insurance, competitive interest rates, and low closing costs. NCA administers VA's Veteran Cemetery Grants Program, which has funded grants for the establishment, expansion, or improvement of 121 state and tribal veteran cemeteries in 46 states and 3 territories. Since 2011, tribes have received more than $37 million for the cemeteries they operate on tribal trust land. The Veterans Health Administration is committed to providing veterans with excellent patient-centered care, and we have many ongoing initiatives currently underway at the local, national, and regional levels to improve mental health and substance abuse treatment, reduce homelessness, and work to ensure culturally competent care is provided to our Native veterans. The COVID-19 pandemic had a profound impact on this country, with substantial impact to our Native communities. In 2020, VA implemented interagency agreements with IHS that allowed us to provide personnel, medications, personal protective equipment, and other resources to our IHS facilities. Through this pandemic, our dedicated VA employees have stepped up on numerous occasions to provide direct health care and support to IHS facilities, tribal health programs, and open the doors of our VA medical centers to accept non-veteran patients through our 4th mission. In VISN 22 alone, over 430 medical personnel have been deployed to IHS and tribal health facilities during the pandemic. Lastly, while VHA has worked extensively to support our Native veterans, the fact remains there is more work to do. Understanding this need, the VHA Office of Tribal Health was established earlier this year and provides VHA with leadership, strategic direction, and policy guidance in our efforts to support Native veterans. In a few short months, they've engaged closely with our VHA leaders, the Tribal Advisory Committee, VA employees, and most importantly, tribal leaders and Native veterans and their families. We look forward to keeping the committee updated on their continued progress. In conclusion, the health and well-being of all of our nation's veterans is of the utmost importance. VA strives to consistently provide high-quality services to the veterans, caregivers, family members, and survivors who have earned them. We are deeply committed to ensuring American Indian and Alaska Native veterans have access to the health care and benefits they've earned. Thank you for your time and your focus on this important topic. We appreciate the partnership with this committee, the Indian Health Service. Happy to answer your questions.
There will be questions, but first we're going to hear from Director So.
Good afternoon, Chairman Tester, Ranking Member Moran, and members of the committee. Thank you for the opportunity to testify on Native veterans' access to Department of Veterans Affairs healthcare and the Indian Health Service. I would like to begin with the IHS mission, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives. This includes, of course, our Native Americans and Alaska Native veterans. IHS provides healthcare services to approximately 2.7 million American Indians and Alaska Natives from 574 federally recognized tribes in 37 states through a network of more than 680 healthcare facilities. As healthcare needs change, the IHS VA and our tribal partners combine our expertise, resources, and efforts to help nearly 145,000 Native Americans and Alaska Native veterans living in the United States. The IHS and the VA Veterans Health continue to provide eligible health eligible Native veterans access to care by bringing that care closer to their home, promoting a culturally competent and quality care, and focus on increasing care coordination, collaboration, and resource sharing. The MOU that was referenced earlier establishes the framework for the Indian Health Service and the VA to leverage our resources and investing in support of our mutual goals. We believe that the newly signed MOU builds on nearly 2 decades of experience and will continue to support our objectives to improve access to health care outcomes for our Native American veterans. The MOU has 4 mutual goals: to increase access, improve quality to our healthcare and services, focus on patients and facilitate enrollment seamless navigation, facilitate and integrate the electronic health record and other health information technologies that affect the health care of our Native veterans, and improve access through resource sharing, including technology, providers, training, human resources, services, facilities, communication, and reimbursement. More recently, Congress directed the VA to reimburse urban Indian organizations the IHS purchase and referred care provided to eligible veterans. Since the implementation of the reimbursement provision in 2012, the VA has reimbursed over $186 million for direct care services provided by IHS and tribal health programs covering approximately 15,000 Native veterans. We are working with the VA on implementing the newly enacted legislation, including the exemption from most of the VA healthcare co-payments for Native veterans and clarification on the related purchase and referred care under the applicable laws. The IHS and the VA continue to deliberate on adjusting tribal consultation and urban confers to increase national awareness of the goals identified in the MOU in order to gather meaningful outcomes and deliverables. In wrapping up my comments, I want to ensure this committee that IHS remains firmly committed to improving quality and access to care for our Native veterans. As a daughter of a Korean War veteran, I had the privilege of caring for my father towards the end of his life. I understand firsthand the challenges of navigating between the IHS and the VA. For my father and all Native American veterans, I have made improving care coordination for our Native veterans a priority at the Indian Health Service. We appreciate all of the efforts in helping us provide the best possible care to the veterans that we serve. Thank you, and I'm happy to answer any questions.
Dr. Upton and Director So, thank you very much for your testimony. I appreciate it very much. I want to start with what I addressed in my opening statement about the copay prohibition. I'm disappointed the VA hasn't implemented the law that we passed 2 years ago to end copays for VA healthcare for Native veterans. It passed 2 years ago. This creates a disincentive for Native veterans to use the VA healthcare facilities, which is opposite of what should be occurring. In September, Secretary McDonough made a commitment that the VA copays for Native American veterans would be eliminated this year. We're almost at the end of this year. So, Dr. Upton, is VA on track to implement the copay prohibition by the end of next month?
Thank you, Mr. Chairman, and I will just say we absolutely understand the urgency and importance of this for the exact reasons you mentioned to eliminate that disincentive. The Secretary has shared publicly that we are going to have this done at the end of the year, and I've talked to him directly about it as well. What I can share with you, Senator, is we are actively working the operational and regulation associated pieces to meet that goal, and that's ongoing as we speak. Because this is still in the regulation process, I have to be cautious because it is still pre-decisional, as you can understand. But I would like to share one thing, if that's okay, because I know how important this is to our community.
Yes.
One of the areas that we are very strongly looking into, and again, because it's pre-decisional, I have to phrase it that way, but we're looking into the ability to make the co-payment benefit retroactive to the date that Congress intended, which is January of 2022. So as we move forward in this process, we commit to keeping you and the committee updated, our veterans updated, and that includes in the coming weeks, as you referenced.
So just to follow up with what you just said, that means you're going to reimburse the veterans for any copays they paid in 2022?
That is a process that we're actively looking into, Senator, which would be for veterans, again, this is pre-decisional, but for veterans who have paid co-payments since January 5th, 2022, we're looking in the ability to be able to reimburse those as part of this process.
And what will determine whether you have that ability?
As we go through the regulation process, that will determine. And so we should know more soon, and apologize that I can't share more just
When,
because of that.
that's no problem. When did the regulation process start?
It has been in process for a number of months now, if not longer. Senator, there are some important complexities to this. We did tribal consultation, sought public comment, and the feedback we received about some components of this were mixed. And we care very deeply about the feedback from our tribal partners, as well as from our new Office of Tribal Health, and that's feeding into helping us make sure we get this right.
So let me get this right. You got feedback from some of the tribal partners that said they wanted to have a copay?
No, the procedural pieces of it, Senator, including how Native status is verified, some of the pieces in place that go into effectuating the benefit.
Right.
Certainly not that the copayment should be there, to my knowledge, but how we act on it in a veteran-centric way that's very sensitive to our population.
Right. So this committee, for all the time that I've been on it, has pushed the different secretaries from different parties, And by the way, I don't think that's a bad thing. I think that this committee has an obligation to, when we see something wrong, to try to fix it and try to push the VA to address that. It's what happened in the Pact Act, okay, to the max. I guess a question that I have is that we did pass this bill 2 years ago. Government is renowned for working slow, and this kind of dots that I. But this doesn't seem like a big issue to me, and I could be wrong. I'm not right all the time, but it doesn't seem like a hugely big issue. I'm going to get to IHS in a second because they don't charge copays. So why is this been? I won't say we're wrapped around the axle, but maybe we are.
Well, what I can say, Senator, is I understand your frustration, and I know that this is so important for our Native veterans, and that's what this is all about. So I apologize for the delay.
You don't need to apologize. I just think that one of the things that I think that our veterans expect out of the VA, and I certainly expect out of the VA, and I'm not a veteran, is that they act in a timely manner. And I think Congress did their job, and oftentimes it's hard for Congress to do its job. So when we finally do our job, it shouldn't take 2 years to get it done. But thank you. Director, so just talk a little bit about IHS. It is not charging copays. Tell me why eliminating the copays for the VA is important from your perspective, and that's not your house, okay? You've got the IHS side of things.
Thank you for that question, Senator. There are a number of reasons why we need to make sure that we eliminate the copay. Number one, there's already in many of tribal country where our veterans have to travel a long distance to get their healthcare services. And on top of that, to layer any kind of copay, in any amount prohibits and really creates that barrier for our veterans to get care. Not only that, if they need care for multiple services, they're paying multiple copays, and so that in itself creates a barrier. So anything we can do to eliminate any barriers for our veterans is what we're asking for. Thank you.
I appreciate that. I would just tell you, I think the point you made is really important. It's not a point that I took into account. And I'm from Montana, where we have large land-based tribes. Some of those reservations are as big or bigger than some of the states we have in this country. And for those folks to drive a long ways and then get hit with a copay too, it really is a disincentive. So I appreciate that you're on it, Dr. Upland, and hopefully you'll continue to make sure that this gets taken care of. I want to talk a little bit about mental health. And since I'm the only one here, you can shut the damn clock off because I'm just going to keep asking questions till I get through them all. Despite serving in record numbers, the needs of our Native veterans has been historically not something I've been particularly proud of, quite frankly. I'm pleased to see that the Fox Suicide Prevention Grant Program created by the Scott-Hannon Act placed a strong emphasis on providing suicide prevention resources to tribes and organizations serving Native Americans. This includes the Great Plains Veteran Service Center, located in a reservation that's pretty close to where my farm is, the Rocky Boys Indian Reservation. I know the VA has also been working to improve its care options for Native veterans. Dr. Upton, can you speak to how the VA works hand in hand with tribes and Native veterans to provide culturally competent mental health care?
Yes, I'd be happy to, Mr. Chairman. And thank you for mentioning the Staff Sergeant Fox grants as well that fund community suicide prevention. In fact, 21 out of 80 that we awarded go to areas that cover tribal communities. To answer your question, sir, there are a number of ways that we work to address culturally competent mental health care. We think it's critical that both veterans have trust to seek our care, that we build those relationships with our tribes at the local level, as well as the work we do regionally and nationally, so that they trust to seek the care within our system. And once they seek that care, it needs to ensure that they are respected for their cultures, beliefs, and values. And so just very briefly, our Office of Mental Health and Rural Health have placed a focus on this in our Native American population. For example, there's been a group working with multiple medical centers, their local tribes, to essentially develop a suicide prevention program focused on Native veterans, both partnering with tribes, because that's so critical, partnering with the community, as well as cultural specific care associated with that. We have a number of other examples, like our Veterans Crisis Line workers have an outreach team that after a veteran calls our crisis line, there typically is follow-up to make sure the veteran is okay to check in. Those secondary responders are trained in Native American culture as well as other pieces. And then there are a few other examples I could share, sir, including culturally appropriate care for telehealth. We have a project working on that. But there's certainly more work to do. And our Tribal Advisory Committee has talked about suicide prevention as a key priority. We're committed to working closely with them on that.
Okay, before I turn to send arounds, I don't know if this is a fair question for you, Stephanie, but I'm going to ask it. In your travels, have you seen the impacts of the VA's mental health from a cultural standpoint?
I've seen impacts of VA's mental health services from a cultural standpoint. I've seen examples of excellence in different pockets of the country. I've seen that occur with the project with Camp Chaparral, which is a partnership between the VA and the Yakama Nation that happens every summer. There's a veterans camp where you bring together American Indian, Alaska Native veterans and VA providers for a week-long kind of immersion program. It's something that's very powerful and has been ongoing for quite some time. And then there's similar kinds of, there's also sweat lodge ceremonies, partnerships with traditional healers in different parts of the country. We've seen a strong impact with that in New Mexico with the Albuquerque VA Medical Center. So like I say, I see pockets of that excellence, but I think that there's still work to do in a uniform way on an enterprise-wide basis, but also considering 574 tribes, 574 unique ways of doing things traditionally. So there's a lot of work to do and a lot to learn as well.
Super. Send arounds.
Thank you, Mr. Chairman. Let me just begin. I want to thank our guests for taking the time to join us here today. Before I begin my questions, I'd like to take a moment to talk about the Native American Direct Loan Program. I think this is a program which, as you're probably or perhaps familiar with, that actually is one that would provide a number of our Native American veterans with an opportunity for a home loan that they may not have today. And so the idea that we have Native American veterans that aren't able to get a home loan because they're in many cases living on tribal trust land seems to me that it's something that we could address. It's no secret that this program isn't meeting its full potential to improve home ownership opportunities for Native American veterans, which is why Chairman Tester and I have introduced Native American Direct Loan Improvement Act. That's 4505. We did that earlier this year. The VA provided testimony on this bill during our legislative hearing in July, and I appreciate the support and the technical assistance the department has provided since then. I spoke with Secretary McDonough yesterday, and he informed me that the VA is also taking some steps internally to improve its NADL or natal operations while S-4505 moves through the process. This is promising news, and I want to thank the Secretary and his team for their continued support for my bill while staying active on this important issue. While I am encouraged by the VA's recent efforts, there is still more work to be done, and I remain committed to getting S-4505 across the finish line to make certain that Native American veterans are able to use this home loan benefit which they have earned through their service. And Mr. Chairman, I really think it's time for us to get this done. I do have a question for Mr. Bell. Since the release of the GAO report earlier this year, your staff has been taking steps to improve the natal program on an administrative level, and I appreciate that. I also appreciate the technical assistance your staff has provided with crafting an amended version of S-4505. I think it's pretty clear that it's going to take some legislative action to get this thing fixed for deserving Native American veterans in my state and across Indian country. I guess my question would be, do you agree that there is still a lot of room for improvement within this program?
Yes, sir. And thank you, Senator, for allowing me to address the panel. First of all, 4505 to us is very important. We appreciate the partnership. We fully support with appropriation 4505 because it does a few things for our program that we just can't do. One is it removes the MOU requirement completely, and which will provide VA the flexibility in establishing agreements with various tribal organizations to expand the NATO program. Second, it expands our NATO loan types, which is huge because while we've seen a very big increase in the guarantee, use of the guarantee by Native Americans, American Indian, as well as Alaska Natives over the past 2 years, it's still important for them to be able to purchase, refinance their properties where they want to purchase and refinance their properties. This allows us to go across the finish line and offer a non-natal loan the chance to refi into a natal loan, as well as from a cash out standpoint, the ability for them to use their equity that they've earned as cash out because maybe they want to stay there and renovate. And why wouldn't they have the opportunity to do that as well? And then third, and certainly not least, is the CDFI relationships that it allows us to create, just to make it even easier for Native Americans to purchase land or to purchase and build properties where they want to. So while we've seen those huge increases, we still need the 4505 to get us across the finish line, and why we think that it's so important. But to answer your first question as well about administratively, we were very excited, and while we are working on 4505, we still believe that there are things that we can do from a MOU standpoint to remove some of those impediments. And really open up the aperture, especially in the state of Alaska, where we have been unable to get our natal loan, some success in those areas. So very exciting and promising, in that arena. So thank you.
Thank you, and I appreciate all the help and the technical support that you've provided us in moving this bill forward. Thank you, Mr. Chairman.
Senator Rounds, I would just say that we're going to try to hotline 4505. And if you can clear it on your side, I'll clear it on mine. How's that?
Let's go to work on it.
All right, baby.
Thank you.
I got to turn the gavel over to Senator Moran because I got to go vote.
Mr. Chairman, thank you. I do have an opening statement, but I will submit it for the record. So I ask unanimous consent that occur without objection so ordered. And my understanding is that Senator Hirono is next to ask our witnesses questions.
Thank you, Mr. Chairman. Dr. Upton and the rest of our panel, thank you very much. for joining us today to discuss issues facing Native veterans. As a senator from Hawaii, I am very disappointed, Dr. Upton, that your testimony neglected to mention Native Hawaiian veterans. As you know, like other Native communities, Native Hawaiians serve in our military at disproportionately higher rates. I know the VA understands the importance of ensuring Native Hawaiian veterans are treated with the same concern as American Indians and Alaska Native veterans, especially following the Secretary's recent visit to our state in October for a field hearing. But it is critical, given the historical lack of parity Native Hawaiians have received from the VA, that Native Hawaiian veterans are always included in our language and our policies. Would you be willing to correct the record to include Native Hawaiians in your testimony and to show how you are engaging with Native Hawaiians as part of the Native American veteran community?
Thank you, Senator, and I appreciate the acknowledgement of our Native Hawaiians who are so important in our veteran population. As noted in our testimony, they are an important part of our Tribal Advisory Committee, and I really appreciate that voice being
Yes.
on the group that advises our secretary. In talking with our region of VAs that works very closely with the team in Hawaii, I know that they are taking the work with our Native veterans very seriously, working on efforts with the University of Hawaii, as well as other outreach to the population there. We certainly welcome the impact and input on how to do better and to continue those partnerships.
So my main point is that Native Hawaiians should never be deemed an afterthought, and that when we talk about focusing on programs that support Native communities or Native veterans, that would be three large groups of Native peoples, and you know who they are. So I'm asking that we need to always include Native Hawaiians when we start talking about all the things that we're doing. I am aware that there are specific programs that support Native Hawaiians. So like other Native communities, Native Hawaiian veterans have long experienced significantly more challenges in accessing resources, an issue that former Chairman Akaka, Senator Dan Akaka from Hawaii, who chaired this committee, fought to fix for years, and one that I am committed to as well. VA's own 2021 National Veteran Health Equity Report Chartbook on Native Hawaiians and other Pacific Islander veterans reported that Native Hawaiian veterans often expressed more issues with care as compared to white veterans. It is clear that the VA needs to increase its understanding of Native Hawaiian culture, outreach to Native Hawaiian community, and build ties with organizations trusted by the community to ensure Native Hawaiian veterans receive the care they deserve. And I greatly appreciate VA's partnership on issues important to veterans in Hawaii. We have a lot of veterans in Hawaii. A big group of them are Native Hawaiians, including, of course, as I mentioned, Secretary McDonald's visit to Hawaii early this year. But it is clear that the VA still has serious work to do to better support Native Hawaiian veterans, and I hope that we can continue working together to ensure Native Hawaiian veterans are getting the care and benefits they earned through their service to our country. And this really requires, in many cases, very different ways of outreach to this community. It requires understanding of the Native Hawaiian veteran community. So I realize you do have a person who sits on your advisory group, and I will be talking with him as to what more support we can provide. I have a question about homelessness in the time I have left. The homelessness among veterans is a huge issue for the VA, and at one point, one of our secretaries said that eliminating homelessness among veterans was his top priority. Clearly, that is still an issue. So we're talking about the 2022 point in time count showed that Native Hawaiians or other Pacific Islander veterans make up the second largest share of homeless veterans on islands, and that veterans overall had twice as many health conditions as compared to the broader population included in the PIT count. In your testimony, you mentioned VA's toolkit to provide, and I quote, background, planning, resources, and programmatic options for organizations interested in finding solutions for homelessness among Native veterans, and this tool does not, again, mention Native Hawaiian veterans at all. Does VA have any strategies that specifically address Native Hawaiian veterans experiencing homelessness? And if so, do these strategies integrate Native Hawaiian cultural practices and norms?
Thank you, Senator, and please know I take all of that feedback very seriously. I do not know offhand about specific programs impacting homelessness for Native Hawaiians, but I will absolutely take that for the record, and we will follow up with you.
Thank you. So homelessness, as well as so many other health issues, including mental health issues and suicides, the Native Hawaiian veteran group experience much higher rates than in the larger population. So, Mr. Chairman, thank you for your indulgence. I'm a little bit over time, but clearly we have work to do. Thank you.
Senator Hirono, thank you very much. Before I ask my question, I again want to, it's not again because I didn't make my opening statement, but I thank our witnesses from both IHS and VA for being here this afternoon. And before I get to my questions, I want the committee to know, the committee members to know that I think this is valuable for us as we presumably are bringing this session to a conclusion. We've been working on these issues for a long time, and progress has been made. There is much further progress we can make before we can make certain that American Indians and Alaska Native veterans are able to take advantage of all the services that they are due and have timely, easy access to health care and benefits from both agencies. I also want to note that for more than a year now, this committee and our House counterparts have been negotiating two end-of-the-year legislative packages, the Dole-Cleland Act and the Strong Act. Both of these bills have provisions in them that would help veterans and their families across the country, including in Indian country. We are very, very close to reaching a final agreement on those bills and being able to get them to the President's desk this Congress. In order to do that, we would need to start the Senate hotline process no later than next week, meaning that we would need to reach a final agreement between the four corners this week. It would be a shame for the topics that we're talking about today, but for a variety of other veteran issues, if we're unable to get to that point after so much time and effort has been spent. Almost every, if not all, members of this committee have something at stake in that legislative package. And I certainly am willing to do everything I can to get there. And I would ask my colleagues on both sides of the aisle to help us get to that point and send another year-end package of important legislative items to the White House. Let me ask my first question, and that is to Dr. Upton. Recognizing the barriers that tribal communities often have had in accessing VA health care and benefits, how is the VA targeting outreach and communications regarding the Pact Act to toxic exposed veterans and survivors in Indian country?
Thank you for that question, Senator, and it is so important that we do this outreach, and thank you to you and the committee for passing the Pact Act that's allowing us to help so many veterans. As I look at the landscape of the work being done across VA and connected with many leaders across our organization, including those who work closely with the team in Kansas, the importance of the tribal relationships in the local community are so critical. And so there are a number of ways that our local VA medical centers, as well as the VISNs, are connecting with tribes, holding events, meeting with tribal veteran representatives, specifically talking about enrollment and now the Pact Act. I have a number of examples that I'd be happy to share with the committee if interested about some really neat ways that our teams have come together with VBA and others in our tribal community to share those benefits. Ms. Birdwell, you may have some background on that too, because she's been doing this for a while, but no, it's a priority.
We'd welcome you sharing those examples with us, with the committee in the future.
Sure. So good afternoon.
Good afternoon.
Senator. With regard to, so since 2018, our team has worked very closely with the Veterans Benefits Administration, VHA, and IHS to hold what we call their claims events or claims clinics, where we go on site and we provide intensive services to assist veterans with filing their claims with the VA, filing for healthcare benefits through VHA. And so that's been an outreach that's been ongoing. Again, it's something that's become a permanent part of VA business practice for about 4 years now. So that's something that I would anticipate that Pact Act outreach would roll into that. Now, I'll pause on that to say that it's a very timely question. I have calls already being scheduled next week. We've been contacted, our team has been contacted directly by VA medical center directors and then local IHS area directors to say we need to, start having some conversations about coordinating how we're going to be doing Pact Act outreach rollout. So the work plan and the conversations are happening, and the plan is basically being built and growing as we speak. I also want to mention that the VA Advisory Committee on Tribal and Indian Affairs, I think their voice and their recommendations will have a very strong influence on how outreach is done.
Have they met specifically on implementation of the Pact Act?
They had their most recent meeting about 2 weeks ago, and they'll have another meeting coming up in April. They also have subcommittee meetings in between their full public FACA meetings. I can't speak for the TAC, but I think that is something that's very much a priority on their radar that they'll be talking about internally.
Thank you.
And then also, something else I just want to mention too is that is very much on the table when it comes to outreach and getting tribal input is broader tribal consultation to get feedback on how effective we're doing and to kind of really hold us accountable moving forward.
Is there any questions that you have me ask the second panel that would help elicit that kind of input?
I think asking them the same question really that was presented to us, just really straight up, what are the most effective ways of really reaching and informing veterans in our local tribal and urban communities with respect to this information? And then, for better or worse, where the TAC has seen, areas where VA can improve, apply some of those to Pact Act outreach as well. So I would just ask them the question directly, what they recommend.
One of the things that at least initially surprised me is the number of times we learn about veterans who do not enroll in the VA, who do not know they are eligible for health care or for benefits. I don't know off the top of my head, although I have a group of experts behind me who could probably answer this question, the percentage of veterans that fail to take advantage of what they are entitled to at the Department of Veterans Affairs. Do you know whether that percentage, that number is different between Native American and Alaska Natives veterans than it is the general veteran population?
I do not know that definitively. It is my impression that is accurate, however, that American Indian Alaska Native veterans enroll in VHA healthcare at a far lower rate than their non-Native counterparts.
Thank you. My time has more than expired, and while I thought I had a free reign and free run, the senator from North Carolina has arrived, and he is recognized.
Thank you, Senator Moran, and thank you all for being here today. I want to talk a little bit, and I will not try to belabor the committee hearing, but I want to talk a little bit about efforts to ensure Native American veterans can access and utilize health care and the benefits they've earned and deserve. And I know firsthand some of the challenges that Native American veterans face receiving VA and non-VA health care and benefits, particularly in the rural part of the country. It may come as a surprise to some, but North Carolina has the 6th largest population of Native Americans in the country, and it's home to the largest tribe east of the Mississippi River, the Lumbee. Native Americans have long and distinguished history of military service, serving in the armed forces at a higher rate than any other demographic, and I think even more so for the Lumbee, not too far away from Fort Bragg. Despite their service, Native American veterans have lower educational attainment, higher unemployment rates, higher suicide rates, and are more likely to have service-connected disabilities than veterans of other races. I want to talk a little bit about the progress. I'm sorry I couldn't be here. We've had votes and competing meetings. I'll review some of your statements, but before I get in to one or two questions I want to ask, give me hope. What specifically are we doing for Native American veterans and expanding care and addressing some of the disproportionate poor outcomes that we have in that population? And maybe if you could speak to some of the root causes.
So, very important question, Senator, and I will start and turn to Ms. Birdwell, as well as potentially our IHS colleagues as well, because it's so important. I would say, number one, when it comes to VA healthcare, the importance of trust and engagement and listening to our tribal partners is the number one thing I hear all the time. And it's so important that when we work with our tribal partners and our tribal leaders, that they're at the table, that we make joint decisions together, and we understand the needs of the local communities. We know there's 574 federally recognized tribes and a lot of different customs, values, beliefs, and approaches, and history and trust that we need to build with them. So I will say is if there is a one common thread I've heard across the board is that local engagement, the trust building, the dissemination of resources by trusted partners, and then when they get in the door, ensuring that they're treated with respect and sensitivity to their culture. There is definitely work to do, as you mentioned, Senator, and just for the sake of time, I'll turn to you, Stephanie, but it is something that's so important.
Senator, I would say that there's actually quite a bit of good things that are happening. One of them, most recently, has been the advent of the VA Advisory Committee on Tribal and Indian Affairs. That advisory committee is a voice directly to the Secretary, and I've seen firsthand how seriously the Secretary takes that relationship and the role that they play in advancing the status of our American Indian Alaska Native veterans. Another very positive success story has been the reimbursement agreements that have happened between the VA and IHS. I believe that to date, there have been approximately 15,000 American Indian Alaska Native veterans who are now enrolled in VHA healthcare over the last decade that previously had no visibility or access to VA. And then at the same time, the Indian Health Service and over 115 tribal health programs have been reimbursed approximately 180 million, which is something that's very much needed in the tribal community. And there are, we've got the Office of Academic Affiliations. It's been a long iterative process, but they have authorization to VA fund 100 graduate medical education students who will do their residency rotations in IHS and tribal health facilities. I could go on, but really there is, it's very exciting. I mean, there are still some very serious challenges, of course, in serving our Native veteran population. But, if you look at where we were 10 years ago, there have been tremendous amount of progress that's been made in a relatively short period of time.
We'll follow up because I'm more about trend lines, programs that are working, and really programs that are not working. Sometimes when we put programs in place, particularly if they're congressionally mandated, and they don't work, they still stay there. So the question we have to ask ourselves, what's working that we should double down on, and what's not working that we should quiesce? We'll make sure that we reach out to you all staff to get more detailed. I won't take you to that level now. Ms. So I want to ask you a question. The Lumbee tribe, I think, first sought recognition about 130 years ago. In the mid-50s, they were simultaneously recognized and unrecognized. More recently, we've seen bipartisan support from the governor, the state legislature. Former President Obama called for recognition. Former President Trump called for recognition during the campaign in President Biden's first term. He also said it was time for recognition, and I believe Vice President Harris was down in Robeson County and said that to the Lumbee tribe members when she was down there. Is it still your understanding that President Biden supports recognition of the Lumbee tribe?
I'm going to ask my colleague here to respond to that question.
Mr. Smith?
Yes, thank you very much for the question. This is a question that we would first recommend being directed to the Department of the Interior, and we can certainly take this back and check in with our colleagues at the Interior. But as you know, there's really two processes for federal recognition for tribes. One that is administratively managed through the Department of the Interior, and then the other through statute. Yes.
Yeah, and I think in that case, I think that President Biden, when they made the conscious decision during the campaign to say that they thought it was time for recognition, understands the two paths, one path that for 130 years has not worked, and another path that is before us in this Congress and every other Congress for over a century. So I was just curious if there had been a change in posture. I have had some discussions with Ledge Council, and I've gotten the impression that they are still behind it, and we're going to continue to work on it. The last thing I would just offer to you all, to the extent that we're talking about the tribal population in North Carolina, of course, we have the Eastern Band of the Cherokee, the Lumbee, but we have 7 other tribes that I feel like sometimes if we're going to really increase their access to care and benefits, you got to go where they are. If you have a program, you hope that they come to it, but I'd like to talk to you all about potential opportunities we'd have to go down into the state and make it very clear that we want to get them every benefit they deserve. Thank you.
Thank you, Senator Taylor. Senator Sullivan.
Thank you, Mr. Chairman, and I appreciate the panel being here. Really, really important issue, certainly in my state. And I just want to begin by, acknowledging what we all know, but I think it just bears repeating about the incredible, what I refer to as special patriotism of the Native American people and Alaska Natives who serve at higher rates in the military than any other ethnic group in the country. Think about that. It's really remarkable when you think about this is a group of Americans who, let's face it, have not always been treated well by their own government. And yet, generation after generation, they sign up to sacrifice, protect, and die for their country. It's unbelievable. I had the great honor, and literally as an honor of a lifetime, to be asked to speak at the Veterans Day ceremony this year at the National Museum of the American Indian on the Mall for the dedication of the really powerful memorial to American Indian, Alaska Native, Native Hawaiian veterans. It was great. Secretary of the VA came too. It was a fantastic ceremony. So I think this is a really appropriate hearing. We all need to do better for these wonderful veterans and their families. So let me first, and I'll just throw this out to the panel. This is the question I had asked the Secretary in a hearing just a couple weeks ago, and then he and I had a discussion yesterday about this. This is the Native American Direct Loan Program, which really hasn't worked for lower 48 Indians well, but it really hasn't worked for Alaska Natives. 40-year-old program, and not one Alaska Native veteran has ever gotten one loan. So the Secretary committed to me, again in a phone call, which I really appreciated, that the VA was going to work for ways to get an administrative fix to this so we can start doing what the bill was intended to do in the program. Can any of you, Mr. Bell, maybe take this one on?
Thank you, Senator. And good news to report, at least we were on the verge of one. We've got...
1 in 40 years, hey, you got to start somewhere.
Yes, sir. I'm not looking for a pat on the back, just a fact. That,
well, that's helpful.
That we're trying to...
Where are they from? Can you tell me?
It's the Metlakatla tribe.
Yeah. So that's great. And I love Metlakatla. I was out there for the VA dedication of their VA cemetery, which was unbelievable. I mean, so powerful. So many veterans on Metlakatla. But let's make sure it's not just Metlakatla. As you probably know, Metlakatla is the only Indian reservation in Alaska, which is great, but this needs to extend beyond Indian country because we don't have Indian country other than Metlakatla.
Yes, sir.
But thank you. Can you do that? Are you ready to fix it that way, you think?
Yes, sir. That was part of the call yesterday that we are...
Were you on the call yesterday?
No, sir.
Okay.
But here's what we know. 4505, the legislation, the bill that we're trying to get passed, Senator Rounds has been working with our staff, certainly since July, gives us a lot of tools in our toolbox to be able to open up and make NATO loans available in those areas where we have the 12 for-profit centers, with shareholders in those lands that we have not just been able to get into. The hope is that by expanding the administrative part while we wait on 4505, so we're trying to expand the administrative look or understanding, sorry, and the statutory language that we have, so that we can establish an MOU with that area, with those partnerships, so that we can, we can start doing loans in those areas. So
Okay.
that's one thing. The other thing is, the reason why 4505 is so important to us is it does away with the MOU requirement, period.
Okay.
So we don't have to worry about that issue. The positive thing about our American Indian, Alaska Native population is we're seeing that from a Native American housing standpoint. So if you look at the guarantee and you look at the direct loan, they qualify for both. It just depends on what land that they're wanting to build or purchase or refinance. The number of guarantee loans continue to rise.
Okay.
In
Alaska too?
In Alaska too, yes,
Okay.
sir. So the guarantee portion of the program is growing. It's now, how do we get the direct loan program to grow along with it? And so hopefully that MOU requirement will help us do that.
Okay.
By lifting some of those issues.
Okay, Ms. Secretary, you have time for one more question? Well, look, we want to work with you on that. It's the Secretary's committed. I appreciate that. He said it in the hearing. He said it to me yesterday on the phone. We all know the end game, the end goal here should be the Native Americans, Alaska Natives should be able to utilize these programs. That's why they were designed. So let me ask, we want to work with you on that. It's complicated in Alaska given our land status and ANCSA, but that shouldn't be a bar to home ownership from the VA if you've served and sacrificed for your country just because we have a different land setup. By the way, which was passed by Congress, right? Wasn't. So here's my second question, and again, maybe for everybody. And I'm sure this isn't just Alaska issue, this is probably a Montana issue, but many of our Native veterans live in rural communities where housing vouchers are not an appropriate solution for vets in needs of housing because there's no rental market at all, or the vouchers are based off too low fair market rents. And these are actually in communities where there's not any housing, and there's often multi-generational crowded family homes. So how can you design a program that's not like, hey, this is the VA loan for that nice house in the city or that nice house in the suburb, but in a very rural community with very little housing stock, when it's based on rental vouchers that just don't work? And I guarantee you there's a problem in Montana and other rural states, not just Alaska, but there's a huge problem in Alaska. Any takers on this? Now I'm beyond the natal issue for other general VA veteran Native loans. Mr. Upton, you want to take
Sure,
it on?
yeah, happy to take that, Senator, and appreciated your very thoughtful opening about the veterans as well. I really appreciate that.
I care deeply about this issue.
Yeah.
For that
it's
reason.
clear. Absolutely. So with regard to housing, the bottom line is it is significantly challenging, as you've talked about. We have a very dedicated group within VA focused on tackling homeless. And as I've talked to them and they do this work, there's a lot of things that they work to do with our tribal communities, but they often say the housing stock is a significant limiting factor. We have a tribal HUD-VASH program that works specifically on tribal lands with our tribal partners, and there's 29 of those that are in existence right now, and happy to share some more background that help with some of the voucher pieces you talk about. But there's a lot of work to do. and we would look forward.
Well, we'd like to work with you and the committee on this. It's just an issue that one size doesn't fit all in the housing market, and we shouldn't penalize Native Americans, Alaska Natives, Native Hawaiians who have this heroic record just because they live in very rural areas. We should design a program around that challenge. So we want to work with you. I think, Mr. Chairman, this would be a good area of bipartisan work on this committee as well.
For sure.
Okay, thank you.
You bet. I've got one follow-up, and it goes with Senator Sullivan's questions on the direct loan program, as it specifically applies to Alaska. The MOU situation, if it is fixed as it is in 4505, does that make this bill workable in Alaska? The program, the direct loan program workable?
Well, it makes it available for us to offer the direct loan program in those areas, because the issue was around the type of land and the type of trust that property was actually in. Yep. So the limitations was the MOU. So this, yes, sir.
Okay. So what we're going to do, because Senator Rounds was in a little earlier, we're going to try to hotline 4505. So we may need your help to get that done.
Yeah, that would be great. Just to clarify, so this doesn't, so Metlakatla is trust land, Indian country, our only reservation. The rest of Alaska, the 44 million acres that the Native people got during the Alaska Native Claims Settlement Act, is actually fee simple land.
Yes, sir.
But that shouldn't, like, who cares, right? It's still for Native veterans. So it just needs to make sure it's not somehow tied to trust land or Indian country or reservation land, because we don't have any in Alaska except for Metlakatla. So is that fixed?
Yes, sir. That's so. Of course, with Metlakatla, they fit the parameters.
Yeah,
of
that's
the
great.
MOU,
We
right?
love that.
So the issue was our authority under the to establish the MOU that we had for national did not fit the other 258 tribal villages and in Alaska, which basically made it impossible for us to establish that direct loan program in those areas. If you remove that piece and you either one, you remove the piece by 4505, or two, administratively, we take the risk, to make that right until we can get 4505 done. Then that also allows us to go into those areas, get a memorandum of understanding done or not, and start asking the next question: is now that the direct loan program is here, what can we utilize across those areas to work with the direct loan program if a veteran needs it, such as down payment assistance or other available programs, so that they have the same capabilities as they do across the
So,
nation.
Mr. Chairman, if we can take one more final look at that before we move to hotline it, that would be great.
Absolutely. So it's been heard in committee, and look, I appreciate what the VA is doing, but it's much better if we do it and then you follow our lead.
Yeah.
And so if we can get 4505 done, I think it fixes your problem specifically.
Great.
All right.
Thank you very much.
Yep, thanks. I want to thank the panel for being here. I appreciate your guys' time, what you do, your attention, and I appreciate you being here and answering the questions forthrightly. Thank you. Pass my thanks on to everybody you work with, too, for the job that they do in the different agencies, whether it's the VA or IHS. So thank you all. We'll get the next panel up. Sorry, Patty. I just released these guys.
No, I have questions for panel two anyway.
Okay, good. So welcome our panelists on the second panel. I'm going to introduce our virtual person first. His name is Leo Pollock. He's an enrolled member of the Blackfeet Nation, a Marine Corps veteran, administrator for the Blackfeet Veterans Alliance, who does great work in my home state of Montana. Well, as I said, Leo is joining us virtually. Next is Larry Wright Jr. Welcome, Larry. Larry is from the Ponca tribe of Nebraska, Army National Guard veteran and the executive director of the National Congress of American Indians. I don't know what you do in your free time, but it doesn't sound like you have much of it. Next, we have Nicholas Lewis, an enrolled member and councilman of the Lummi Nation, who's been talked about earlier here today, vice chair for the National Indian Health Board, a Navy veteran who serves on the VA Advisor Council on Tribal and Indian Affairs. Thank you for being here with us, Nicholas. And finally, joining us also virtually is Sonia Tetnowski, president of the National Council of Urban Indian Health and CEO of the Indian Health Center of Santa Clara Valley. Sonia is an enrolled member of the Makah tribe, an Army veteran, and also a member of the VA Advisory Committee on Tribal and Indian Affairs. Appreciate all four of you being able to testify in this hearing. We will start in the order that I introduced you, and we'll have Mr. Pollock virtually. Please begin.
Chairman Tester, Ranking Member Moran, the rest of the committee, thank you for having me here today. Funny enough, we're actually here with this meeting that we are here today to be here for you to give my testimonial. I actually left another meeting for access for VA healthcare for our veterans here, not just on a Blackfeet reservation, for all of Montana. Our current IHS, the last veteran that was ever served was in 2014. We're actually in talks with IHS, the Billings area office, as well as the Browning unit, so that we can reestablish that. We're also working with our Southern Pagan Health Clinic to see if there's any way that they can provide services that may be lacking in between the VA and the IHS, that they can help fill that gap. And as we read through, to do those shared services. One of the big things that I know we were looking at is that our reservation, you know, it's not a small reservation. It's over 3,000 miles that we're looking at, square miles that we're looking at. We have two counties that are actually part of our reservation, the Blackfeet Reservation. That is Glacier County, which does make up the bulk of that. And our other is Pend Oreille County, which is the south, and that actually encompasses the small village of Heart Butte. The reason why we're fighting so hard to reestablish our outpatient clinic for our veterans here on the Blackfeet Reservation, as well as surrounding communities, is that, as we all are aware, you know, Montana winters, they're not easy to navigate. Sometimes some of us are stranded for days on end until we're able to get back into civilization. We have small communities such as Bab, St. Mary's that are to the north of us. And there oftentimes that should be a 30-minute trip with ideal driving conditions. However, given our severe weather that we're in right now, we're actually in a winter weather advisory until tonight or early tomorrow morning. And we did have some VA representatives that traveled up from Helena. They actually drove as far as Great Falls yesterday so that the trip was a little safer and easier for them to be here on a decent time for us for our meeting earlier today. So one of the biggest things we're looking at for our veterans here, and why we want to make sure that we can reestablish our outpatient clinic, it's like we said, when you have ideal conditions and what should be a 30-minute drive one way, all of a sudden that turns into an hour drive one way. And given the ever-changing weather conditions that we have here, that can easily turn into 2 hours, which, you know, the numbers just keep adding up as we go. We currently have, from what I've gathered, you know, we have well over 700 veterans here in Glacier County. That's not including Pend Oreille County. We just want to make things easier for them. But one of the things that we also face with that, and why we want to reestablish our clinic here in the reservation, is that a lot of times it's the financial barriers that our veterans face here. They may not even have the financial means to get to any of their VA appointments, more so if those appointments are in Fort Harrison and Helena. Many of our veterans can't afford a vehicle or don't have the transportation means to get to those appointments. sadly, what happens with a lot of our veterans is that when they don't have that, they kind of just give up and they just move on from there and kind of relegate themselves to this life that nobody's going to help them. However, we are here to help them, and we've been doing that. I've only been in this position I'll be coming up, starting my 3rd year in January. And in that time, we have slowly began to recreate some other services for our veterans. And we would just like to make sure that we can expand on that for our veterans and make the accessibility that much easier for them by having to fight all of these other barriers that we look at here in Montana. Blackfeet Reservation, I know it's not just our reservation, but the other reservations within Montana as well. So that's what I'm here for, is to help be that voice for my fellow veterans, and that we can do that and get them the care that they so deservedly should have.
Thank you for your testimony, Dale. Appreciate you joining us today. Next, we've got Larry Wright, Jr. You have the floor, Larry.
Good afternoon, Chairman Tester, Ranking Member Moran, members of the committee. My name is Larry Wright, Jr. I'm a former tribal chairman for the Ponca Tribe of Nebraska. I served 11 years in that role. I currently serve as Executive Director for the National Congress of American Indians. And I thank you for this opportunity to testify on behalf of Indian country and Native veterans. As was shared earlier in your opening remarks, Chairman, this committee is well aware of the valor and service of American Indian, Alaska Native, and Native Hawaiian veterans to this country. Also, we know the high rate that our Native people serve in the military, and I also know that despite this impressive record of service, the committee knows that the lack of health care provided to these veterans upon returning home is unacceptable. Obtaining health care for Native veterans often means navigating both Veterans Health Administration and the Indian Health Service. The primary health care provider in most Native communities for many of our Native veterans is IHS. Thus, one mechanism for improving the health of Native veterans is to improve the IHS system, which has long been woefully underfunded. Additionally, unlike the VA system, IHS continues to be subject to the harmful and disruptive effects of government shutdowns and short-term stopgap measures because it does not yet have advanced appropriations. This is precisely why NCAI has long been in support of advanced appropriations for IHS, and it is one step that can be taken immediately to help both Native veterans and Native communities more broadly. Focusing on Veteran Health Administration more directly, there are many barriers Native veterans encounter in accessing care. One alarming statistic is that Native veterans use VA healthcare disproportionately less than non-Native veterans, despite having the disproportionately higher percentage of veterans with a disability. One reason for this is that Native veterans seeking to get to a VA facility might have to make a 200-mile round trip. And in the case of Alaska Native veterans, it may be much, much higher. NCAI recommends that the VA, in coordination with the Department of Transportation, work with tribal governments to facilitate transportation from tribal community hubs to Veterans Health Administration hospitals. Additionally, we urge the continued exploration of alternative options such as telehealth services to ensure that all Native veterans are being reached. When Native veterans are able to get an appointment and make it to VA health care facilities, all too often they are met with a poor understanding of Native culture, which creates another barrier to Natives trying to access services. We are hopeful that the recently created Tribal Advisory Committee within the VA will assist with some of these issues and applaud the efforts made to create that entity under law and to fill its seats. That said, more needs to be done to address the cultural competency. For example, many forms and questionnaires do not address cultural context or risks. Additionally, as a result of incurring traumatic brain injuries, and some Native veterans struggle with second language retention and require services to be administered in their native languages instead of English. And finally, there is a dearth in Native professionals and individuals with adequate understanding of tribal communities to truly allow individuals with health concerns to be open and honest and trusting of the system, something that is essential to achieving positive outcomes for those in need. Given the importance of cultural competency, NCAI Veterans Committee has expressed the need to increase access to tribal veterans service organizations to assist American Indian and Alaska Native veterans with benefits claims and accessing other VA services. Similarly, more government-to-government consultation between the VA and tribal nations can also generate new methods for improving cultural competency across health services. Before I close my remarks, I also want to briefly highlight one other issue impacting Native issues, and will note that I've highlighted a few others in my written comments. Despite the service that they provide to our country, homelessness and housing insecurity remains a major concern for our Native veterans. A simple but critically important step to combat this issue is to reauthorize and make permanent the Native American Housing Assistance and Self-Determination Act. NAHASA reorganized the system of housing assistance provided to Native Americans through the Department of Housing and Urban Development by eliminating several separate programs of assistance and replacing them with the block grant program. This block grant program has successfully been used by tribal nations across the country to focus on specific housing needs in their own communities. However, NAHASA expired 9 years ago, and we cannot afford to let this critical legislation go unauthorized any longer. NCI urges members of this committee to support S 2264, the NAHASA Reauthorization Act of 2021. This legislation has been reported out of the Senate Committee on Indian Affairs, marking the most progress any NAHASA reauthorization bill has made since 2013. Additionally, many of the provisions in S 2264 are included in the Senate Transportation and Housing and Urban Development Appropriations Bill, and we strongly urge this committee and other members of Congress to support these efforts. Reauthorizing NAHASA will also help Native veterans struggling with homelessness by improving the HUD Veterans Affairs Supportive Housing Program. The program has been a nationwide success because it combines rental assistance, case management, and clinical services for at-risk and homeless veterans. Unfortunately, this program is not fully available to Native veterans living on tribal lands, which again is why NAHASA reauthorization is critical. Also in the housing space, NCI urges the passage of S 4505, the VA Native American Direct Loan Improvement, and we appreciate those comments on it today. This program has only provided 190 loans to Native Americans nationwide over the last 10 years. This legislation would help increase the number of NADL-administered loans by allowing veterans to refinance existing non-VA mortgages, utilizing the NADL product, and would also allow veterans who have built homes with other sources of construction financing, such as Native CDFI loans, to still use this as permanent financing. It also provides grant funding for Native CDFIs, tribal nations, tribally designated housing entities, and nonprofits to assist with outreach, homebuyer education, and other technical assistance to Native veterans seeking home ownership financing. Finally, I want to take a moment and acknowledge that when the U.S. government does engage in meaningful dialogue and consultation with tribal nations, solutions can be found. We don't need to look any further than the Native American Veteran Parity and Access to Care Today, the Pact Act, which was signed into law nearly 2 years ago. That piece of legislation has improved accessibility to Veterans Health Administration services by limiting co-payments for American Indian and Alaska veterans, and we are grateful for Senator Tester and his leadership on getting this passed. It is a valuable demonstration of what we can accomplish for our people, and as was said earlier, even though that was passed 2 years ago, we still need to get rid of those co-pays. Thank you.
Next up is Nicholas Lewis. You have the floor, Nicholas.
Good afternoon, Chairman Tester, Ranking Member Moran, and honorable members of this committee. Thank you for holding this important hearing and inviting the National Indian Health Board here to testify with you all today. The National Indian Health Board, or NIHB, serves on behalf of all 574 federally recognized tribes. My name is Nicholas Lewis. My traditional name is Jetskatum, and I serve as Vice Chairman on the NIHB and as Chairman of the Northwest Portland Area Indian Health Board, and as a member of the VA TAC. I also have the honor to serve my people of the Lummi Nation as a council member for the last several years and as a proud Navy veteran of 8 years. I signed up for the Navy when I was 17 years old, so please know that serving this country and my people with honor has always been a priority to me since a young age. Chairman Tester and Ranking Member Moran, I know you understand and have long been champions for Indian country. So in the interest of time, I will be brief and ask that my full testimony be submitted for the record. More than half of Native veterans are estimated to get their health care through IHS or in combination with the VA. That is why coordination between the VA and IHS and this committee's oversight for that coordination is vital. It is not enough for any agency officials to testify that they are committed to this coordination unless and until coordination is institutionalized and all staff are trained and held responsible, and any improvements made now and through this work would erode over time. When it comes to veterans' health through IHS, coordination is not the only issue, as IHS has not received an annual budget on time since 2015. The new normal is stopgap funding through continuing resolutions, which results in our primary health system suffering from disruptions in providing services to our people, but most importantly, our veterans. And when federal government shuts down, which it has, the problems get worse, and our lives are put at risk because of this. The Northwest Portland Area Indian Health Board has passed a resolution at our last quarterly board meeting entitled Condemnation of Harm to Indian Healthcare System Caused by Disruptions in Federal Appropriations and Resultant Continuing Resolutions, which we'll be happy to share with you all as well. As you know, the VA receives an annual advanced appropriations protecting them from shutdowns and stopgap funding. In 2018, the Government Accountability Office reported how advanced appropriations have helped the VA. Our veterans are looking for that same help for IHS. For many of us, getting our health care through IHS, as we've heard from others on this panel, is not only a choice, but it is a necessity, which I personally can attest to, as I only receive my health care personally through Indian Health Service. The Indian Health Service is vulnerable to shutdowns and stopgap funding, and that is not right. And it needs to end, and we need your help in fixing this injustice. We respectfully ask the committee to talk with your colleagues on the Appropriations Committee and those in leadership about including IHS advanced appropriations in the final fiscal year 23 agreement. Please make them explain why they can't get this done. Because the excuses we've been hearing so far when we travel back here to the Hill about why VA deserves advanced appropriations, but IHS does not, seem unreasonable, unfair, and downright cruel. It violates the trust responsibility that our ancestors sacrificed everything for when they signed the treaties with the United States government. And when you help in stabilizing IHS, you're not just helping our people, you're also helping our Native veterans who we're here all advocating for today. Finally, I want to turn to homelessness and housing. And Mr. Chairman, I know these issues are things that you feel strongly about, as do I. Homelessness and housing are public health issues. We need to look closer to the social determinants of health across the board, and we need the VA to focus on those things as well going forward. Studies show that homelessness and substandard housing are risk factors for so many of the health problems we have seen across Indian country today. Our veterans are more likely to be homeless, with studies showing that 26% of our low-income Native veterans are affected by homelessness, compared to only 13% of low-income veterans overall. Work is still needed to address homelessness for veterans, and we call on the senators to help us in removing these funding barriers, to provide direct, reoccurring, and sustainable funding to tribes and tribal organizations, and to explore innovative solutions to end the housing crisis in Indian country. Today, the VA, HHS, and HUD are announcing a Native Veteran Homeless Initiative to increase access to care and services. The initiative will ensure that Native veterans are aware of and have access to available resources. This awareness of resources for Native veterans themselves, as well as for the tribes supporting their veteran members, is an issue that we've identified that can be addressed by increased targeted and ongoing administration outreach and messaging. For example, the Tribal HUD VA Supporting Housing Program, our Tribal HUD VASH, has existed since 2015, but awareness of the program and its policies is still lacking in our tribal communities. Mr. Chairman, to quote you, sir, the VA can outsource work when it makes sense, but it cannot outsource the responsibility for taking care of their veterans, whether they receive care at the VA or care in the community. They are responsible for both, and we would add that IHS is included in that. What you're trying to do with Senate Bill 2172 the Building Solutions for Veterans Experiencing Homeless Act of 2021 is a good thing and a step in the needed right direction. And we will do what we can to help get you across the finish line with that bill. In fact, we welcome the opportunity to work with you and Ranking Member Moran and any member on this committee on any piece of legislation that supports improving the health outcomes for all of our veterans in this country. This now concludes my testimony, and I want to thank you all for the opportunity to be here with you all and your continued efforts in improving the lives of our veterans. Thank you.
Thanks, Nicholas. We started this panel hearing from snowy Montana. We get to our last testimony. Our last panelist is Sonia Tetnowski from sunny California. So, Sonia, you're up virtually.
Thank you. Good afternoon. My name is Sonia Tetnowski. I'm a citizen of the Makah tribe, president of the National Council of Urban Indian Health, and chief executive officer of the Indian Health Center of Santa Clara Valley. I also serve as the chair of the health subcommittee within VA's first ever advisory committee on tribal and Indian affairs. We're grateful to you, Chairman Tester, and to Senator Sullivan for your partnership on the VA Tribal Advisory Committee Act of 2020. I'm sharing my views here today as the president of NACUI and not in my capacity as on the advisory committee to remain in compliance with the Federal Advisory Committee Act. As a U.S. Army veteran and as an urban Indian organization leader, it is imperative that our physical, mental, and cultural needs are addressed in a culturally competent way. As you know, 67% of Native veterans live in urban areas, and more than 50% use Indian healthcare providers. We need the ability to go to a facility that understands, respects, and recognizes our unique needs. Urban Indian organizations provide a wide range of health and wellness services. In fact, we currently serve 7 of the 10 metropolitan areas with the largest Native veteran population. Therefore, it is critical that VHA work with us to improve the health outcomes of Native veterans across the ITU system of care. Since more than 50% of Native veterans use the ITU system for their healthcare needs, securing advanced appropriations for the Indian Health Service is critical. Gaps in federal funding put lives at risk. In fact, 5 patients died during the last shutdown. The risk is too big and the price is too high for us to continue without advanced appropriations. When the VHA received advanced appropriations, the president said, "The care that our veterans receive should never be hindered by budget delays. Yet, we have not protected our Native veterans who receive care from our ITU system." During the last government shutdown, my clinic supported another urban program so that they could remain open. This should not be happening to our patients and specifically to our veterans. All this due to funding delays caused by the shutdown. Therefore, I urge this committee to help secure stable funding for all Native veterans by supporting advanced appropriations for IHS. It's been about 2 years since we worked with you both, Chairman Tester and Ranking Member Moran, on the Pact Act to remove co-payments for Native veterans receiving VA healthcare. In September, VA committed to putting this legislation into effect and eliminating co-pays for Native veterans by the end of this year. But it needs to go one step further. We ask this committee to encourage the VA to allow self-attestation in determining Native identity for VA co-payment purposes, because many Native veterans may not have the kind of ID that defines them as Indian or urban Indian. NACUI advocated for years, and I testified many times for the inclusion of urban Indian organizations in the VA reimbursement program. We're grateful to this committee for fixing this parity issue. However, many urban programs are experiencing difficulty enrolling, and only 1 of 41 completed the process. We need additional technical assistance and the ability to modify these agreements so that they work within the scope of services of our respective sites. I'd like to thank the VA for working with urban Indian health programs, but an urban confer policy between VA and our clinics would solidify this relationship. During the rollout of COVID-19 vaccines, some veterans who went to the VA received vaccines and were told to go back to their Indian clinic. This highlights the need for greater coordination among all entities serving our Native veterans. In June, the Health Equity and Accountability Act was introduced with the first ever legislative text establishing urban confer policy with the VA. We would love to see this committee include language in future packages related to Native health care. In conclusion, Native people have a long history of distinguished service to this country, and we owe it to them to address these issues and remove these barriers to ensure greater access to care. Thank you for allowing me to speak on these critical issues affecting Native veterans. My full testimony was submitted for the record, and I'm happy to answer any questions. Thank you.
Well, thank you for your testimony, and I hope it is sunny in California. I am going to defer to Senator Murray for her questions.
Well, Mr. Chairman, thank you very much for holding this hearing. 13 years ago, we had a similar hearing where a number of issues were raised about access for Native Americans to VA healthcare and benefits, and we made a promise to take care of our veterans after their service, and it is clear that more work does need to be done to live up to that promise to our Native veterans. I do want to thank all of our witnesses for being here today to speak on these important issues, and I especially want to thank Nick Lewis from the Lummi Nation. You heard from him that he served in the Navy and has been a leader in his community and works on these issues on a national stage. So welcome and thank you to all of you. Mr. Lewis, let me start with you. I've been a very strong supporter of the HUD-VASH program to get supportive housing and case management services to veterans with high needs, but we know that HUD-VASH program has had its challenges, especially with the shortage of affordable housing in our state of Washington and challenges VA faces while recruiting staff to serve our rural areas. In the Pacific Northwest, a number of tribal housing authorities use the tribal HUD-VASH program for veterans who are at risk or are already experiencing homelessness in areas that can sometimes be very hard to reach in bad weather or that have long drive times to the closest VA medical center. How would you suggest to all of us that VA improve its outreach in the tribal HUD-VASH program in general to make sure that Native Americans are actually able to access and utilize the program?
I think one of the things that comes to mind, and I was talking with our staff in the back, and many of the organizations that we sit on as tribal leaders, and this is just something simple, is creating a listserv for tribal veteran directors and tribal communities that veteran directors can opt into to receive updates. When we get those kind of emails, whether it's through NCAI or NIHB and the work that we do, those organizations put a lot of good information out. And that would be something that I think our veteran director back home in Lummi would appreciate, but we don't have that, or we're not aware of that when I asked him specifically. I think one of the other things that is a challenge, and Senator Sullivan kind of alluded to it earlier as well when he talked about his tribal members in Alaska, is you can have a good program like the HUD-VASH program, but if there's no houses in that community, or when there is, the rent is so high that it isn't able to be used. One of the things we have recommended through the VA TAC, and it's not gone through its full process yet, and I can't speak on behalf of the full TAC, but we have advocated for increased HUD-VASH assistance. I think one of the other things that we would recommend is working with HUD more between the VA and HUD, because the VA doesn't build houses, right. But HUD does. And so one of the things that we could do is work with HUD a lot more to work on specific HUD veteran housing across Indian country, because a lot of the things that we've heard from the testimony is there's no housing, especially in Indian country. So those would be big helps.
Okay, very much appreciate that. And on the issue of healthcare access, in your testimony that I read, you mentioned some of the shortfalls with VA's existing MOU with IHS. In Washington State, we've worked really hard with the VA to make sure veterans do have timely access to high-quality care. And given some of the geographic challenges and wait times, veterans sometimes have to use non-VA providers through the community care network to fill access gaps. What would it mean for Native veterans' health outcomes to have services closer to home and providers that are culturally competent?
I think that means everything when you're seeking health care. One of the things, as I mentioned, my healthcare, I only go through IHS and our tribal clinic. That is because I'm comfortable with them. They know me. We have a history. And one of the things, and I'm going to speak personally, around mental health, and I've heard a lot about mental health. There were some things that we've all gone through during COVID where we all struggled. I had to go through mental health, and I made appointments to go that. I actually quit going because it didn't feel right going to an office that I knew somebody that was being paid for to provide a listening session for me. But what worked for me is one of the things that we say in Lummi, our culture, our Chelangan, is in nature. It is up in the mountains, it is in the water. And for many of those that know me, I think especially during a time that we've had to use Zoom, I would take meetings in the mountains or on the water because that's where it was filling my spirit. And so when we talk about getting care in our communities, it's that. It's in a place that fills your spirit and your soul that you can't get going to somewhere that's foreign to you.
Right. Okay, excellent. Really appreciate it. And again, appreciate all of our witnesses today. Thank you. Thank you, Mr. Chairman.
Thank you, Senator Moran. Now we have Senator Moran.
Chairman, thank you. This is really a question for all the panelists. The Pact Act was signed into law, as we know. Its effort is to expand access to VA health care and benefits to toxic exposed veterans and survivors. I want to be certain the VA is doing everything it can to spread the awareness among veterans and their families about the Pact Act so that they can enroll in VA healthcare systems and file claims for benefits they are entitled to. How can the VA improve? This is the question. How can the VA improve outreach about the Pact Act to toxic exposed veterans in Indian country? And will your organizations help spread the word about the Pact Act, or tell me what you are doing to do so to those toxic exposed veterans and their families in those communities?
Well, I think, thank you for the question. I think one of the things that we hear time and again from our Native veterans, especially in our committees, are the tribal veteran service organizations and that help that they can bring in on the local level, regional level, that is tribal specific, culturally specific, where they have trust from the veterans in those specific areas and help them navigate the system as a whole. But in this particular case, when you talk about the Pact Act, having that understanding of somebody who's willing to do the outreach, has the ability to meet them where they're at, makes a big difference. And especially if it's somebody from the community that they have that long time trust in. And I think the more we take advantage of that particular program, the more opportunities that will present themselves to Native veterans who may just be disenfranchised from the system as a whole, or because of frustration, whatever that might be. And then when you take in the logistical pieces to it as well. But I think that expanding that program, strengthening that program will help go a long way in Indian country.
Mr. Wright, let me take your answer, and again, others are welcome to respond. But so is the VA doing that? Is there evidence they're going to do that? Have there been conversations that suggest that that is what is going to take place?
Good.
I can add a little bit to that. In sitting on the VA TAC, and I'm glad that Sonia is here as well. I sit on the committee with her. She chairs our health subcommittee. And one of the things that is the previous panel, Stephanie had mentioned, we had meetings a few weeks ago, and our next meeting will be in April. And I'm thankful to our TAC and to the VA staff that we work with, that they'll be hosting the next meeting in our area in Portland. And one of the things that we've talked about, and we've talked about this as tribal leaders a lot, and hearing from senators and Congress people, when we come to these meetings and we travel a long way, to sit here and just get talked to, it's not meaningful, right? And one of the things that, as a veteran myself, and what Larry had mentioned, trust is a big thing. And when you look at veterans across the country, whether they're tribal or not, there's a lot of our veterans that have lost trust for one reason or another. And what I'm going to be working with the VA TAC on and proposing, those details haven't been worked out, so it's like I can't speak that this is going to happen, but what we're pushing for and pushing, I think more broadly, is that when we host those advisory meetings, that we also afford our veterans in the community that we listen to them and not talk to them. So one of the things we're proposing is that our VA TAC is that we work with veteran organizations in the Northwest, Washington, Oregon, and Idaho, where we meet with veterans where they are. We create the space for their voice to be heard. And our job as an advisory committee is to amplify and bring up their concerns to you all so that we can remove these barriers in good faith.
Anyone else?
Yes, thank you. You know, that's one of the toughest things we have and one of the best things that seemed to work for here in Blackfeet country was to do the VA town halls. It gave our veterans the voice. It gave them the floor where the last time the Vision 19 team come out, they basically asked, they said, what is it you want us to do? And we cut the mic loose and we was able to turn that, and we gathered so much more information with that short, I think it was about a 2-hour meeting, and we gathered so much more because our veterans had the voice. They had the floor. They were able to tell the VA directly and specifically what each veteran wanted, because not each veteran is or has the same wants and needs depending on what it is. So I think for us, given the size of our demographic that we have here, the town hall seemed to be one. As long as we could get those spread out, it helped us spread the word and also gather information for all of our veterans here.
Useful advice for the Department of Veterans Affairs, useful advice for elected officials in this committee and in Congress. My time has expired, and I think we have votes that began at 4:45. So I'll ask this for the record, and then I'll make another brief question and be done. I'd be happy to hear from any of you what concerns you have regarding the VA's partnership with tribes to help make certain that Native veterans have access to culturally competent and geographically acceptable burial sites. And again, I'll save that. What could the department do to improve that circumstance? And if any of you have opinions about that, please submit them in writing. And then just generally, I would raise the question of American Indian and Alaska Native veterans. A lot of the circumstances you face are distance. What can we do to better utilize community care, telehealth, and other mechanisms that close that distance to make it much less of a burden when those veterans are seeking care? And I would indicate that one of the things that I am troubled by is any suggestion that the Department of Veterans Affairs is going to alter the standards by which community care can be attained as far as distance and time. And again, if any of you have those thoughts or have thoughts for me in those regards, I'd welcome that input.
One brief comment on that. And I watched your hearing on community care recently, and I was thankful to hear a lot of the comments that I heard from the senators around the table, as well as some of the responses from Secretary McDonough when he was here. But when I think of community care, and others may have a difference of opinion, but when we're talking about our veterans going through IHS in our communities, that is community care. And one of the things our veterans have been asking for is they cannot always, as many of our panelists have said, they can always travel to the VA. And in that hearing on community care, the VA has shortages just as well as anywhere else. The VA doesn't always have capacity. And I'm not saying that Indian Health Service is always perfect either, but our veterans would rather go through, and as the data shows, and I think it was a data I said on the SAMHSA Advisory Committee, and they stated that 52% of veterans don't utilize the VA. That means that 52% at the SAMHSA data that was reported are going through community care. And our veterans, we have over 90 veterans in Lummi. Only 2 are utilizing the VA services, is what I was told by our billing department. And so it's showing that our veterans are going through our health system more. And so what we're asking for is the full faith and credit. And I know we're going to be working on amending the MOU between our tribe and the VA. But our veterans are saying they want to get their health care through our IHS facility instead of being able to be forced to go to travel 2 hours to get to Seattle. I just wanted to add those comments.
I appreciate that, Mr. Lewis. And I was thinking during the testimony that probably in much of Indian country, the Indian Health Service is the community care. When I think about it, more likely as the local doctor or the local hospital. In tribal country, that very well may be Indian Health Services. I'll ask my staff here, but it causes me to wonder whether the use of IH care, Indian Health Community Care, Indian Health Service care, is considered community care under the Community Care Act. I don't know that, but I wonder what criteria are necessary for you to do that, and maybe it's just the MOU. I'll follow up with my team to make sure I understand how this works. Thank you.
If I may.
Go ahead.
Senator, can I add something?
Sure, go ahead, Sonia. We'll get
Hi,
you.
thank you. I guess I just wanted to ensure that there's thought around our urban Indian health programs as well. Because there are no tribes within many of our geographical areas, but most of our clinics were placed in relocation sites, including mine in San Jose. Most of our Native community and Native veterans would rather be seen by us as a Native provider. So although I absolutely support and completely agree with all of what Councilman Lewis just shared, it also applies in an urban setting. So I just didn't want to disregard that as well. Thank you so much for the opportunity to share.
Absolutely. Larry?
No, and I appreciate that because my comments were going to be very similar. My tribe was terminated in the 60s and federally reinstated in the 90s, and we were reinstated without a reservation. And part of our Restoration Act by Congress established 15 counties across Nebraska, Iowa, and South Dakota, and several of our counties are in the two biggest cities in Nebraska. And so we have health clinics in those areas and VA hospitals just down the road. And even when you take out all the logistical, scheduling, financial barriers for travel and geography, even when it's right down the road taking a bus, our veterans want to come to our facility because of the cultural competency, because of that care and trust that they feel that they have there. And we see many other Native veterans taking advantage of that as well, even though the VA is just down the street. And so I think when you look at the issues as a whole, it's systemic, and we can point to several things, but I don't think you can fix one without addressing all of them, and they all really do go together.
A takeaway, and Senator Tester and I just were talking about this earlier, a takeaway is that then means that Indian Health Services has to be a consistent, constant provider, open for business on an ongoing basis, based upon the reliance that Native Americans place in that service. Okay.
Well, thank you, Senator Moran. A lot of water went under the bridge in the last 6-7 minutes. I will say, going back to town hall meetings by the VA, that is very good advice by the ranking member, and it also applies to elected officials. Listening is really important. It's why we have consultation with tribes. You guys know that. There are challenges in Indian country that are specific to Indian country, and one of those challenges was brought up by Mr. Pollock with large land-based tribes in particular. And I really don't care where it's at. I mean, you either got snow, you got heat, you got problems when you got distances. And I would just like to know from you, Mr. Pollock, you talked about geographical and logistic and financial barriers. You're working with the Blackfeet Veterans Alliance. How are you guys working to overcome those challenges of bad weather and no money?
Chairman Tester, one of the biggest things we are working with is we try to build partnerships with other veteran services and organizations, not just located here on the Blackfeet Reservation. Like I stated, there is one Rocky Boy, they've recently rebranded. They're called the Great Plains Veteran Services Center. And one of their departments is transportation department. Right as I came on, we built a partnership with them to where they are actually one of our primary transportation providers to provide transportation to our veterans to appointments at no cost to the veteran besides maybe a meal. However, that is one of the things that between my program and their program, we are working on to where we can create some kind of funding to even buy a meal for those veterans that may not be able to do that. So one of the biggest things for us, given this, and we continue to do that, I've started reaching out to the Fort Belknap tribe. Most recently, it was Spirit Lake Reservation in North Dakota. I gave a presentation to them, let them know, hey, we're here, that, you know, we got to work together as there's times where resources are stretched thin, no matter what it is, if that is finance, transportation, all of the above. That is our biggest thing, is to create and build those partnerships across all tribes, no matter where they're located. If there's something that we can do to help, or maybe we have somebody that we can get in contact with, because we also have veterans who are still have ties to the reservation. However, you know, they don't live here. They live in Great Falls, they live in Havre, they live in Missoula. So we try to make sure we create all these partnerships throughout the state to get whatever it is we need for our veterans to better serve them, no matter where they're located.
Thank you, Leo. Mr. Wright, Executive Director of NCII, which is probably the premier Native American group out there, represent a lot of different tribes. Could you talked about the co-paid issue in a little bit in your opening statement. Can you give me some information about how you're hearing or you're seeing the co-pay issue play out with tribal members, generally speaking?
Yeah, I appreciate that. And, you know, we know that the Pact Act was a very crucial piece of legislation for Indian country. Knowing that it got passed and it's still not implemented, when we talk about the impact of just costs in general, when you compound that issue with trying to just get to the clinic, to get to your appointment, and the cost that's associated with that, and knowing that going to the VA for a Native veteran, they have to have this copay on top of it, and sometimes scheduling, when you add the scheduling factor in where they may be behind, it gets canceled, and they've already incurred that cost, or the tribal nation, as the gentleman said before, they're taking on the extra cost to help get veterans there. And so all of those things are just another layer of a barrier. And when you add that copay on there, especially for Native veterans and Native people, knowing that's a trust and treaty responsibility that our ancestors fought very hard for, and with the formulation of this country, and have paid many times over for of land given up, blood, sweat, and tears, to have that as a veteran, a Native veteran, on top of everything else is very hard. And that's, whether that's a personal issue or leads to that, again, that disenfranchisement where we feel that we're not good enough. And we know that may just be another factor of saying, for a Native veteran, I'm not going here because I'm not valued. But I can go to my tribal clinic, my Indian Health Service, where they know those values, and take that on. But that creates another burden on that system. Or if it's an IHS clinic, or if it's a tribally run clinic, which even compounds that further. Yeah. And so we haven't said that much, but that's still another factor in there.
So one of the things that you brought up in that answer that a lot of the folks that we serve with don't understand is trust responsibility. Now, I know for a fact Senator Moran is not one of those. He understands trust responsibility very, very well. But it's specific to Native Americans. And I don't know of another group that has that kind of agreement. And so I think it's really important we keep that in mind. And for that reason, it's an issue that I've brought up in both panels, and hopefully we can get it solved. Look, we've had a good hearing today. I want to thank everybody for being on each panel. Thank you to the witnesses. I look forward to continuing to work with VA and IHS and tribes and tribal organizations to ensure that Native American veterans have access to the health care, the benefits they've earned for their service to this country. I would also like to say that it has always been something that we've tried to achieve here, where the VA and the IHS becomes a seamless as far as service provided. Now, look, I know follow the money because that's typically where it's going to go. But the truth is that we've had challenges with hiring nurses and doctors and everybody in the VA. We've also had challenges in IHS. It's the same thing. And it's about resources, truthfully. And so we need to continue to work towards that because I think it's the right thing to do for our Native American veterans who serve at a higher rate than any other minority in this country. So with that, we'll keep this record open for a week, and this hearing is adjourned.